take a deep look at how cardiovascular computed tomography can help your patients. Join one of SCCT's hands-on workshops to get real case experience. With virtual access to reading software, learners interact with image-based cases while being guided by experts. SCCT workshops cover a wide range of topics, such as coronary evaluation, plaque features, grafts, valvular heart disease, transcatheter valve planning, structural heart disease, congenital heart disease, masses, pericardial pathology, and other commonly encountered clinical scenarios. All workshops include case credit and CME. Visit scct.org/workshops for more information. That's scct.org/workshops.
Alastair, I'm not feeling myself lately.
Well, what's wrong, Praveen?
I've just been feeling really dark in my core, you know?
Gosh, that sounds pretty grim. Anything else bothering you?
Well, there are occasional spotty, bright moments, even sometimes a bright rim around life, like a ring around a napkin or something. But, more often than not, I feel like I'm just pushing outward into nothingness, trying to be positive about my remodeling, but I just can't quite get there,
Wait a minute. Dark core, spotty, bright moments, napkin ring, positive remodeling.
Alastair, I would like to thank you for just letting me be so vulnerable with you.
Oh, for goodness sake, Praveen. Oh, right, let's just get on with the podcast.
I guess that introduction was a little too high risk for Alastair. Am I right? Okay. All right. Anyway, well, listeners, welcome back to the Donut of Destiny, the podcast on all things cardiac CT for anyone interested in cardiovascular imaging. My name is Praveen Ranganath, and I'm a radiologist in Dallas, Texas.
And my name is Alastair Moss, and I'm a cardiologist in Leicester in the United Kingdom. Today, we are joined by an esteemed guest who truly needs no introduction to the cardiac imaging community.
That is right, Alastair. Today, we are joined by none other than Dr. Todd Villines, who will help guide us through a conversation on cardiovascular disease phenotypes and cardiac CT. Dr. Villines is a world-renowned cardiologist, a professor of medicine at the University of Virginia, past president of the SCCT, past chair of the ACC's Imaging Section and Leadership Council, author of over 200 manuscripts, a recent past editor-in-chief of the JCCT, and the first chief medical officer of Elucid Biomedical Imaging. Dr. Villines, welcome onto the podcast.
Well, thank you both. It's such a pleasure to be with you all. I'm really excited. I just want to congratulate you both on how much I enjoy this podcast. So I'm especially just honored to be a part of it today.
Excellent. Welcome on board, Dr. Lyons. So to start off, there's been a significant rise in the number of cardiovascular imaging applications across all modalities. And using cardiac CT, we can now quantify perturbations in coronary flow down the course of epicardial vessels. We can use computational fluid dynamic models to assess the structural integrity of thin-capped apheromas. And we can subtype plaque composition using an array of techniques, from Hounsfield attenuation signatures to detecting unique features contained within perivascular fat. Some proponents have argued that we now live in an era of too much medicine, where we risk over-medicalizing problems rather than addressing the major health conditions within society. So are we now in the era of too much imaging in the field of cardiology?
Well, that is a terrific question. At my core, I got into cardiac imaging and coronary imaging using CT because I was convinced, like all of you, think back to your days in training. I was convinced that our paradigms, our pathways, that we were evaluating patients, whether they be symptomatic patients who come in with chest pain or whether they be risk assessing asymptomatic patients. I was convinced that they were not only imprecise, but that we could do better. I look back in my cardiology fellowship, and I did almost like 600 catheterizations, and I think about half of them were normal. And of those, it was usually the fact that we were using non-invasive tests that I thought were simply not accurate. So yes, there's been a rise in imaging in general. I think we've, as a medical community, we have really emphasized using non-invasive testing and hopefully reserving invasive testing for patients who we really think are going to benefit from it. And so, the question is a good one. Are we doing too much imaging? Well, I don't think we've been historically doing the right type of imaging. If you look at the volumes of procedures, at least use United States data, we have been, the foundational test, for example, in many of our symptomatic patients has been nuclear imaging, predominantly with SPECT imaging. And I think what we've learned is that, and you are aware of this vast amount of data, that we can be more precise and we can be more selective, and that there's an advantage for using coronary CTA. And that's something I've devoted my career to, is helping to study, is coronary CTA value added, not just to the individual, but to how we practice as a whole. And I think the guidelines recently have recognized that we can change how we do imaging, and we can hopefully only do imaging when we think it is going to be valuable for the patient's care. It's going to improve their care and especially improve the prognosis, and then better inform patients and providers how to be managed. So, the guidelines that just came out in the fall of 2021 were a huge step forward. They've kind of nudged us. They said, listen, not only is coronary CT a class 1 recommendation for a first-line imaging agent for both acute and chronic symptomatic patients, they've reminded us that the benefit there is really based on prevention, and that we can see plaque and see non-obstructive plaque and perhaps treat these patients in a more precise way and hopefully do a better job at preventing heart attacks long term. It also nudged us because it said, while there are a lot of non-invasive options, and kind of lumped them all together as class 1, they kind of said, there are some tests that might be preferred over SPECT imaging, PET imaging, or perhaps stress CMR. And so I think the challenge we have is this tension. We know we have better tests than what we're doing every day. It's whether we can afford it as a society. And I think where CT shines is that it is affordable relative to these other tests. We know that the world has lots of CT scanners that, barring our recent contrast shortage, contrast has usually been not a challenge to get your hands on and relatively inexpensive compared to radio tracers and the technical challenges we see with other testing. And so that's really what I think we as a society have had to grapple with, is how do we make that shift and evolve our imaging, not do more imaging, but do smarter imaging. And so that's kind of my hope. Now, the second part of your question is, gosh, now we're overwhelmed with data. So, it used to be as simple as, hey, we could do a coronary CT and we would say, okay, you're normal, you're non-obstructive, or you've got some degree of stenosis. And now we've realized that there's so much more information that can be extracted. And you mentioned several of them, whether it be pericoronary adipose tissue assessment, whether it be, assessing changes or trying to estimate invasive flow reserve from static CT images, whether it be, quantifying plaque. And the question I always get is, do I really need that level of detail to manage patients, and how much incremental value do those additional measurements, which if you pick up a journal today, it's like half the journal, if not more, are these really advanced quantitative measures of CT. I'm a big believer that we should be maximizing our value, but I also recognize we have to be pragmatic, and that, for anything to truly move the needle and improve outcomes on a population level, it has to be accessible, affordable, has to be proven, and it has to be repeatable. So, a long answer to a great question.
Excellent, Todd. I think that opens the stage for a really interesting discussion. You brought about irrefutable data that at least us imagers and many of the non-imager community fully recognize, supporting the value of cardiac CT and the value in the evaluation of our patients with chest pain. But you also recognize an interesting dichotomy, the one between public health and global health, and the other between personalized, more bespoke medicine. Todd, I wanted to get your take on where cardiac CT falls in that dichotomy. Is it more towards the global and public health approach, or can it be used as a precision medicine tool? And if so, how can we use that precision phenotyping of disease in improving the management of our patients?
Well, I think it's really both. I think if you look at, I used to be astounded by the fact that we would see patients with chest pain. We would do a stress test, for example. They would come back in, or we would relay the results to them and say, hey, good news. Your stress test was normal. And they would say, okay, well, this is good news. And then we would, shift to say, but oh, by the way, you've got some risk factors that need to be addressed. And we would literally go back to using things like risk calculators. And yet we had just put someone through a $1,000 to $2,000 pathway of tests that the patients often thought you would image their coronary atherosclerosis. And what we were doing tests to detect the very end stage of atherosclerosis, advanced ischemia. And so there was this real disconnect between what we were testing for. We were testing for really advanced stage atherosclerosis, knowing up front that most of the people we're saying won't have it. We know if you look at data within the nuclear cardiology field, the majority of the tests are negative. And yet we would fall back to this relatively imprecise population-based approach, doing 10-year risk scores, et cetera, and so forth. And so I think CT is both in the sense that it can improve population outcomes by identifying patients with actual atherosclerotic disease. And that to me is a huge, if you use the calcium scoring data in an asymptomatic population, we know that atherosclerosis imaging is almost in every study better than our risk scores. And we know that CT can even improve upon that through its ability to identify all forms of plaque, calcified, non-calcified, and affect prognostic, and also detect prognostically significant stenosis. Stenosis that may not be improved, by the way, from a risk standpoint from stenting, but is still prognostically important. And so, that to me is from a population basis as well as a patient basis. I think that's why you've seen the guidelines change, because guidelines do take both approaches. They try not to recommend science that is aspirational, that can't be performed today. And I think that's why you saw very presciently the NICE guidelines years ago take that approach. And if you look at the rationale in that document, it was very much population-based. It was based on overall global health within the UK, as well as cost savings based on the use of CT, and they even ended up considering some FFR CT as part of their decision making. But I think it's both. It's interesting if you talk to patients and you use some examples of what we screen for, what we look for. I have a lot of interest in both the asymptomatic and symptomatic populations. We look invasively for things like colon cancer, right? We involve an anesthesiologist. People can actually die. There are complications from that, albeit rare. But importantly, we do so because of both population and individual risk improvements. And I think atherosclerosis imaging has to make that leap into the public discussion. People often ask, hey, did you get your mammogram? Have you had a colonoscopy? Well, you often don't hear people ask their parents or their friends, hey, has anyone looked at, do you have plaque? Have you talked to your doctor about imaging? Or have you had stress tests that look at plaque? Or quite frankly, have you even had CT scans within the last 5 to 10 years that have looked at your heart? So much of which goes unreported to patients. So I think it's both. I think CT can give us both, from testing in symptomatic, asymptomatic patients, and can be very individualized care as well.
And Todd, we've learned so much over the past few years about different ways of trying to phenotype disease. And clinically, a lot of that has been based around a qualitative assessment. I guess the closest we've got to a quantitative assessment in a clinical perspective is trying to put a stenosis threshold on a lesion. Do you think that it's always going to be the qualitative approaches that we're going to be using, or do you think there's going to be a movement into more quantitative metrics and within the clinical arena?
Well, that is really the biggest question today. If you think about how we read coronary CT, we just came out with CAD-RADS 2.0 and advise all of our listeners to go and look at that document. If you really look at how we have read coronary CTs for the last decade plus, they read a lot like a cath report. Right? CAD-RADS 1.0 was, what is the worst stenosis, right? And that's what you got a number with, right? And that was based on a visual assessment within a certain range. That was semi-quantitative, clinically very valuable, prognostically very important, and it works. The other part we would do is look at plaque features and try to assess risk, right? And we did this again very crudely. Do you have 2 or more of these features in any plaque in your coronary tree? What we've learned over especially the last 5 years, is that much of the drivers of risk are things that we don't routinely measure. So if you think about, some of the data that's come from Scott Hart, the quantification of low attenuation plaque, for example, whether you look at machine learning algorithms that predict prognosis, almost always, the things that we're measuring are important. Stenosis is important, As I've mentioned earlier, things like CAD-RAD scores and some of the qualitative high-risk plaque features are important. The problem is they're not significant. They have a fair bit of variability between readers. We know that that's the case, and some of that's inherent to image quality variability. But many of the things that predict risk, in fact, usually in most machine learning algorithms, most of the things that predict risk, we are not measuring. These are things like quantitative and overall plaque burden, assessing plaque risk features, and so on and so forth. We're used to quantifying calcified plaque with a calcium score, but those are things we're currently leaving on the table. We're quantifying them in a vague way. CAD-RAD's this iteration 2.0 does incorporate a plaque score, but even that plaque score is just kind of looking at it and saying, well, maybe I can use a calcium score, or maybe I can just look at the overall coronary tree and say mild, moderate, severe amount of plaque, or if I want to go in and calculate a segment involvement score. So the question is always, I think any of us as imagers want to maximize the clinical information that we can derive from a CT scan. The patient went through it, they paid for it, they have an expectation, or I think as a medical field, we would all want to maximize the clinical information from that. So I think inherently, we all would like to have tools that can quantify plaque burden, plaque risk, and other measures that we are just hard to do manually, that you'd have to spend all day to do manually. When people have done that, we have seen, in several different trials, they tend to be the biggest predictors of risk above and beyond just the way we're currently reading CT scans today. The question is, of course, can we do it quickly? Is it accessible to patients who get CTs around the country, around the world? And is it affordable? And those are the questions that I think right now we're grappling with. In addition to some technical questions, are these measures reproducible? Are we measuring, when we say we're measuring things like certain attenuation plaque or certain types of plaque, how accurate is that? How reproducible is that? And how much does that stand up with variations in image quality, et cetera? What's really exciting, though, is I think as we see the technology evolving, we're seeing that these measurements are probably only going to get better, not worse. For example, things like photon counting CT. Now, this is very early in this process, but as those scanners become more ubiquitous, I think we expect to see that over the next 5 to 10 years. We would hope that these measures that are now available in whether it be commercial products or research products that make measuring these things much more easier and hopefully more accurate and reproducible, the hope would be that they would even get more accurate over time.
Todd, I wanted to get a little more granular on that exact point that you're mentioning, some of the technological improvements and on the hardware side as well as the software side in terms of how we can make that reproducibility more robust in the evaluations that we have for quantifying plaque. At present, we know that total plaque quantification, calcium scoring tools are pretty robust, but those involved in, say, non-calcified plaque or low attenuation plaque, while have shown signal, are not necessarily as reproducible. So you mentioned things like photon counting CT to help improve, say, spatial resolution of exams. I'm certain that there are software solutions, for example, solutions that are offered by our colleagues at AutoPlaque, at Elucid, that may improve some of the reproducibility of our evaluations. What do you think needs to be done in order to use the hardware and software to make things more reproducible and therefore applicable in a clinical cardiovascular medicine perspective?
Well, it is. There's so much research going on in this area, as you know, quantifying plaque and I call it quantifying and characterizing plaque. All of these approaches that you just mentioned take a little bit of a slightly different approach, but they all have really the same goal: is they want to quantify plaque. They want to characterize it in a way that has prognostic significance and imparts management or helps people make management decisions. Back 5 years ago, even, a lot of people said, well, why do you need to do that? I can look at a CT and tell whether you need to be on a statin or aspirin. And the reason I think it's becoming more interesting is twofold. Number one is that we just have so many more preventive therapies today than we did 5-10 years ago. And so, the question then becomes in patients who are getting imaged, who are already on maybe some of those therapies. For example, maybe they're on a statin. And we have the ability to look and say, can we characterize plaque And perhaps there are phenotypes where we would say, you know what, they're not really doing well on statin therapy. They're failing statin therapy. They have all of this high-risk plaque. Or maybe they've had a CT scan in the past and we can benchmark that and see that there's been plaque progression. And if it's above a certain threshold, maybe we can truly be more personalized in our care. Now, that's the aspiration. And it only becomes valuable to do those types of quantification if you have different therapies that you can offer people besides just a one-size-fits-all high-dose statin therapy. And we now have that, whether you look across the armamentarium of additional lipid-lowering agents, PCSK9 inhibitors, inclisiran, anti-inflammatory therapies, the new SGLT2 inhibitors and GLP-1 receptor agonists, et cetera. And so the world of prevention has got much more complicated, and it kind of demands better precision from imaging. But your point is very well taken, is that the first thing we have to do is ensure that any of these approaches, whether it be whatever plaque software you're referencing, the first thing is doing the studies where you do test, retest reproducibility. Is it across different ranges of image quality? Because I think we have to be able to say to patients that what we're telling you is in fact reasonably likely to be true. We know that none of them will be 100% accurate, and they'll always be influenced by variations in image quality. And so that's I think the first part. The hardest part for CT, as you know, is doing accurate segmentation of the not just the lumen but the wall of the coronary artery, separating that from what is healthy wall versus diseased tissue versus epicardial adipose tissue, and that is a real challenge. And how the software handles that, I think, is something that we all should have significant interest in. And I think the other challenge we have is we see different terminology. So for example, we've seen multiple studies with low attenuation plaque using a certain threshold. And so, that's one way of using terminology. Other people will use more biologically based terminology, things like lipid-rich necrotic core as another term. And so I think people having to become somewhat familiar with these different terminologies is a challenge for providers. And I think ultimately what needs to happen, what we hope to see happen, is that each of these approaches are assessed for their ability to predict events. And right now we're starting to see some of that data come forth, but it certainly needs to be much more robust. We want to see perhaps even some comparison studies. How do these different approaches between different software manufacturers, some of which, they use different levels of ground truth. Some machine learning approaches will use a ground truth of being expert readers. Others attempt to replicate histology by using histologic inputs into their models. And again, even some of the thresholding techniques are very different amongst all of these different software. And so, we hope to see in the literature, how do they compare? And I think that's something we currently lack.
Todd, I'm really fascinated in this sort of field of reproducibility science, and particularly when you use the phrase ground truth. We've always historically reference that to another diagnostic test or potentially referenced against intracoronary imaging. I'm just wondering what you think the ground truth should now be for CT now that we're moving into this era of plaque quantification.
Well, that is one of the biggest challenges in plaque imaging, as you probably know. I mean, I think in a perfect world, we would all love to have a ground truth that's based on histopathology, where we could say what we're imaging corresponds to this under a microscope. I think that's probably ideal. The challenge is how to get it. And the reason I say that is because, getting good, fresh, properly processed coronary plaques that have been assessed by an expert under a microscope are very challenging. I mean, we think about how you would do that logistically. I think it's the ideal ground truth, because we know that even if you use intravascular imaging like IVUS, the studies show that when it thinks there's a lipid-rich necrotic core, thin cap fiber atheromas, the accuracy is not very high when you actually do compare it to histology under a microscope. And so our non-invasive, probably the best test we have is near infrared spectroscopy, or NIRS. Probably does in OCT for thin cap fiber atheromas. Using those, I think, are important, because I think we published a meta-analysis years ago that shows that coronary CT volumetric assessments can correlate very well with IVUS. So volume measurements do require a validation, at least with intravascular ultrasound or intravascular imaging, ideally, to show that the volume of plaque that you're measuring is important. The real challenge is when we characterize plaque. And that is where even with intravascular ultrasound, it becomes very, very challenging to actually say, which plaque is a high risk plaque, which plaque represents, these lipid-rich necrotic core, thin cap fibroathroma plaques. And that's where I think, we in CT have kind of many times skipped steps. And what I mean by that is we've said, okay, all of this low attenuation plaque predicts bad outcomes. We don't really exactly know what that means or what that correlates to histopathologically. And so I think that's been the biggest challenge in the field. Now, a lot of people would say, well, it doesn't really matter as long as what you're measuring predicts risk. And that's certainly, there's certainly some merit to doing that. But I think using the ground truth is challenging. I think most software we see, because it's challenging to get, histology samples to actually train your models against. Most of it's just based on expert readers and Hounsfield unit scales. I think ideally, if you could get those samples, everybody would be using histopathology. It's just a challenge of actually getting those samples, having them processed correctly, interpreted by experts, and then training your models to recognize them using CT images. That would be, I think, an ideal way to do things.
So, Todd, dovetailing from what you've started to describe about predicting risk using these tools, I wanted to focus on the patient level versus the lesion level when it comes to how cardiac CT is evaluating these patients. We've seen from recent trials like ischemia that a more binary approach to categorizing ischemia on the patient level doesn't necessarily translate into an improvement in outcomes clinically. So the question then is, should we start to adopt a more lesion-specific approach towards how we evaluate cardiac CT in the context of patient outcomes? And if we do, is this going to be more helpful for supporting intervention or supporting advanced medical therapies? Oftentimes, when I try to get myself involved in a more lesion-specific approach, I run into the situation where I have an indeterminate phenotype, for example, an indeterminate FFR CT value. But when I try to go back to the data to support decisions based on that, I run into a bit of difficulty, a bit of trouble, because those gray zone phenotypes don't really have much data from the diagnostic test perspective to support a decision one way or the other. So while I know that there are caveats with the patient level analyses, there are similar caveats with the lesion specific analysis. And I wonder if what you're describing can help unite those two ideas into something more helpful for managing our patients.
Well, I think this is where the next several years are going to really be helpful. And I think we're going to learn a lot about some of these management paradigms. I mean, really what you hint on regarding plaque is this age-old argument about, is it high-risk plaque or is it high-risk patients? In coronary imaging, I tell people it's not or, it's and. Right. So I think and this is what I think where plaque quantification will really help us. And so we know that there are patients who might have not a lot of plaque, but they may have high risk lesions. And so both of those things are certainly, I think, helpful. And we know that there may be patients who have a lot of plaque who don't have a lot of high risk lesions, or vice versa. And I think that CT, obviously the global amount of plaque, I think if you look across most papers, is probably the most predictive. But we've also learned from papers like the 1K plaque study led by Leslie Shaw that in fact, certain plaques may be at a point where they're very, very unlikely to ever cause an event based on the degree of calcification. So I think it's both. And I think this is where plaque quantification will help us, because right now our abilities to actually answer your question is that, should I change my management based on what I'm seeing on CT? Right now it's very challenging. You say, well, I can see the calcium score and I can see how much plaque there is. There's some possibly high risk features, but I'd like to be able to dig a little deeper. And I think quantification may actually be helpful to answer the question, is the patient overall high risk? Yes or no? And then do they have high risk plaques? Yes or no? And then if so, how much of those things? How much do they have? Right now, our approach is very binary. If you get a CAD-RAD score, it's a number, and you get a high risk plaque plus or minus. And so I think, yes, does it matter if there are high risk plaques? Yes, the PROMISE study has taught us that the presence of high risk plaque phenotypes is prognostically important. Is there a high-risk patient phenotype that I want to know, or a plaque burden, overall plaque burden I want to know about? Also, yes, we know that also matters very much so. And so I think both of those things are helpful at the patient level. When you go back to the patient and say, should we change the therapies that you're on? Are your therapies working? How should I counsel you as far as what lifestyle changes to make, et cetera? Now, you also raised the question of FFR. And I think the field of imaging has really struggled in many ways on how to use fractional flow reserve. Because yes, we know how to use invasive fractional flow reserve, but gosh, how should this be used from CT? And I tell people it's a really helpful decision tool. And again, it goes back to maximizing the data that we get from CT. And I think as somebody who's been a user of FFR CT, I think, yes, it's helpful when it's normal. It's probably helpful when it's abnormal for decision making, but there are certainly gray zones. I think one of the things that the field is evolving towards is, and we think this is where perhaps next generation FFR CT that includes plaque might help in those gray zone decision making. So for example, you get an FFR CT in a certain area. I think we know intuitively, in fact, we learned from the Credence trial that when you quantify plaque, it can predict invasive FFR just as good as some current approaches, which use simply the geometry of the vessel. The vasodilatory capacity of an artery is intrinsically affected by how much plaque you have. And what does that plaque look like? For example, if you've got lipid-rich necrotic core and a big bulky plaque, you're probably not going to have much good endothelial function and vasodilatory reserve. That is much more likely to be an abnormal invasive FFR. Regardless, even if two patients have the exact same vessel geometry or degree of stenosis, the patient with that ugly, really abnormal plaque is much more likely to have an abnormal invasive FFR. And so getting back to your dilemma, when you have these FFR values that are in this gray zone, I have always argued that to interpret FFR correctly, you should integrate that, not just with the degree of stenosis, but with the type and amount of plaque proximal to that stenosis and involving that stenosis. And I think that's where, as we see the field evolve, we've seen some machine learning studies using kind of next generation approaches with FFR and I think some plaque-based measures of FFR CT that hopefully will help you and other providers like you when you have those gray zone results.
Excellent, Todd. This has been such an informative discussion, and you framed so many issues here with the clarity and expertise that we've come to expect. I'm just wondering, now that we've got your thoughts primed, whether you could just think about where the field is moving over the next 5 to 10 years. What do you think we can look forward to in the near future?
Well, I think as we've hinted already, I think we need to always remember our roots. And our roots are, while we've spent a lot of time discussing these quantitative approaches to maximizing the diagnostic and prognostic information from CT, that we have to remember that right now around the world, there are many, many, many places that you simply can't get a coronary CT. There are places even here in the United States where it's very challenging. There's been payer coverage challenges. Much of that is now moving forward, and I think advancing to the point where, thanks to the evidence base primarily, thanks to all of you and all of our listeners who have developed this evidence base and made it the most robust of any imaging modality. I think that's highlighted by the fact that it's the only level of evidence, a class 1 indication in the U.S. guidelines. And, of course, we know the class 1 evidence in AESC and NICE. But so I think importantly that I think we always have to remember that, doing high quality CT is our first and foremost, call to action. And I recently just went back and read the very first president's page that was in the JCCT in 2007. And in fact, that's what Stefan Achenbach, the first president of the SCCT, reminded us to do, is that above all things, we should always be delivering very high quality imaging. And so I think that we need to remember that, all of us share a role to make our programs the very best, to educate our colleagues, to train people to do CT and send them out in the world to do very high quality CT. Because even today, the patients, if you look at relative, for example, to SPECT in the United States, it's still a fraction of SPECT imaging. There's so much room for growth. I think secondly, we're obviously going to see an explosion of data science and, the ability to extract data from these very, very, very multi-dimensional CT data sets. And to combine that with the clinical data, how do we take all of that data that's available in the EHR and to try to better educate our patients? And I think most patients, when you ask them, gosh, would you like to know your risk to the best of our abilities? Of course, most people would say yes. And again, I think when you combine that with the advancing armamentarium of preventive therapies, it's an exciting area. What we really need are imaging enriched trials that say if you have this phenotype or you have this phenotype, here's the best combination of medicines. Because now it's becoming really complicated. When do I use a PCSK9 inhibitor? When do I use ezetimibe? When do I use anti-inflammatory therapies? In light of all the data I can get from my CT scan, you're giving me plaque phenotypes, plaque quantification, the pericoronary adipose tissue data. How do I actually translate that? And I hear from a lot of providers, that's what they want. They're almost overwhelmed with how much data we can give them in a report, particularly from a report where you've done advanced plaque analytics. And so I think we need the clinical data to start incorporating phenotype-enriched patients and randomizing them into clinical trials and testing whether what we think is true, that these patients with these high-risk features and high plaque burdens is actually true, and can we modify their risk? And that's where the field right now, we know that their risk is higher if they have certain amounts of plaque, types of plaque, et cetera. We know it's higher in and above and beyond their clinical risk factors. What we need to see is how to optimally treat them to truly translate that to care. And I think the last part that I think is currently the group of patients that we've not yet gotten into, but we're starting to see studies, is the asymptomatic population. The SCAPAS trial, Miami Heart, has really kind of challenged and said, well, wait a second, maybe there is a role for very low dose coronary CT in asymptomatic patients. And that's a huge, Pandora's box, because there is risk to doing that. There's the oculostenotic reflex that may be an actual harm for these patients, but the potential to better treat these patients above and beyond calcium scoring and above and beyond risk factors, I think is a real exciting, area for patients. And I'm really excited to see that evolve.
Fantastic. Todd, this conversation has been incredible. And we really thank you for your time and expertise of coming onto the podcast to enlighten us and our listeners about all of these very interesting ideas. And before we conclude, I just wanted to get any final thoughts from you about the state of the field.
Well, I tell you, there's never, for listeners, there's never been a more exciting time to be involved in cardiac CT imaging, because obviously we focus a lot just on coronary imaging and atherosclerosis imaging, but it's just the field of procedural planning. And when I first started doing this back in the early 2000s, it felt like we had a pretty big headwind. People kind of said, "Oh, you radiate these patients and you generate pretty pictures. Where's your evidence?" And I think today we've really got a lot of momentum in the field. And it's an exciting time. And I think that for those people who are just starting out in imaging, there's no better time to be involved in cardiac CT. I'm super excited about the field. And I think I would predict that in the next 10 years that it will be the dominant imaging modality in really across medicine, to include patients who have known coronary disease. And I think that's another untapped area where we just need more research. But these newer imaging modalities with photon counting CT, I think really will drive that.
Excellent. Thanks again for joining us on the podcast, Todd. And to our listeners, thank you very much for tuning in. If you like what you hear from us on the show, please rate, review, and subscribe. Once again, this is the Donut of Destiny. Cheers.